Our webinar today will discuss treatment of craniopharyngiomas, an update on current trends in surgical, medical, and radiation therapy. My name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association. Delighted to introduce our speaker today, Dr. Kevin Lilhei. Dr. Lilhei is the Director of Neurosurgery at the University of Colorado and Director of the Neuro-Oncology Laboratory, with his research interests revolving around the treatment of malignant gliomas. In particular, he is interested in studying the role of the immune system, intracranial tumor recognition, and eradication, and is exploring the use of various tumor vaccines as adjuvant therapy for the treatment of malignant gliomas. Thank you so much for joining us, Dr. Lilhei. You may now begin your presentation.
Welcome. My name is Kevin Lilhei, and today we're going to be talking about craniopharyngiomas, as Jillian said, an update on the current trends in surgical, medical, and radiation therapy. In this talk, we're going to start by discussing the origin of these tumors and then give an overview of their frequency of occurrence and presenting symptoms. We will move from there to talk about treatment, touching on new developments in surgery and molecular biology in particular. We're not really going to talk too much about radiation therapy. As you know, I am a neurosurgeon, so my perspective will be a bit different in this discussion than a pediatrician, a pediatric oncologist, or an adult oncologist. So from there, let's move on. What is the origin of craniopharyngiomas? Craniopharyngiomas are rare, benign tumors that are derived from cell remnants of a structure called Rathke's pouch. And if you look on the slides, on the left-hand side, I've got a little arrow pointing to this red infolding. This is a 7-week-old embryo. So the Rathke's pouch forms very, very early in pregnancy, and this pouch is going to go on to essentially turn into the anterior pituitary gland, which is shown in the middle of this left side. The red is the pituitary gland, and then seen under C is the fully developed pituitary gland. This is the anterior pituitary gland, whereas the blue behind it is the posterior pituitary gland. The majority of craniopharyngiomas occur in this area that we call the suprasellar area, or occur along, if you look on the right-hand side of the slide, occur in this area of the pituitary stalk. And just above the pituitary stalk, up above, is the optic chiasm. So when these tumors grow, they grow upward, pushing the optic nerves upward, and they grow superiorly into this orange area, which is into the brain in an area called the third ventricle, or also the hypothalamus. About 50% of the tumors will grow down into the pituitary gland itself, and this is why there is such a high rate of hormone insufficiency associated with pituitary tumors. I threw this slide in just to remind people of what the pituitary gland does, and it's really the central hormone gland of the body. It produces the anterior pituitary gland, produces TSH to drive the thyroid, ACTH to drive the adrenal glands, growth hormone, LH, FSH to drive the testes and the ovaries, and prolactin, which is useful during pregnancy for the production of milk. The posterior pituitary gland secretes only 2 hormones, the most important of which is the ADH, or antidiuretic hormone. We're going to talk a little bit today about diabetes insipidus, and it's because of the lack of this hormone, ADH, that patients develop diabetes insipidus, and that's the inability for the kidneys to concentrate urine, and basically leads to fairly significant dehydration. So what about the occurrence of craniopharyngiomas? In the United States, craniopharyngiomas account for about 2.5 to 3% of all primary brain tumors. The incidence is felt to be about 1.1 to 1.3 cases per million population, with the worldwide incidence being about 1.34 per million. A little bit higher in children, 1.44 per million. And the typical age of occurrence of craniopharyngiomas is split between a very young age group, 5 to 14 years of age, and an older age group between 50 and 74 years of age. So if you take the statistics here, in the United States, there's about 400 cases of craniopharyngioma each year, and this is split pretty evenly between children and adults. So there's not a lot of cases, and that's why experience in treatment takes such a long time. There's a slightly increased male predominance, about 1.1 to 1.4 to 1 over females. So this is two graphs. The one on the left is from the Central Brain Tumor Registry of the United States, where they looked at the occurrence of craniopharyngiomas between 1990 and 1993. And the right is a longer series from 1972 to 1995 in Los Angeles County. And the point of these two graphs is, if you look, the peak age group in both is about 5 to 9 years of age in youngsters. And then there's this second peak in the adult population, and that tends to be a little bit more variable between studies, but generally between the 50 and 65-year-old age group. Craniopharyngiomas tend to occur in two types. When the pathologists look at the tissue that's been removed at the time of surgery, craniopharyngiomas can be subdivided into papillary, as shown on the top of this slide, and it's called papillary. Obviously, you can see these little papillae shapes that it tends to form. And then there's the adamantinomatous type, which is shown in the lower side of the slide. And these have a more skin-like appearance to them. They tend to have calcium, which is in the upper right corner, right here where my pointer is showing. And they also tend to form primitive structures, and they can form primitive teeth, primitive enamel, and that's kind of where they get the adamantinomatous title to them. So when you look at these two subtypes, the adamantinomatous is virtually the only type that occurs in children. It also occurs in adults, about 50 to 86% of adults, so it's the primary type of tumor that occurs in adults as well. It's commonly calcified. It tends to be a little bit more infiltrative, and what that means is that it really sticks to the surrounding tissue, which makes it a little bit more difficult to remove surgically. And then the tumors tend to be filled with this motor oil, kind of dark brown fluid within them, and that has these shimmering cholesterol crystals, so very, very characteristic. The papillary craniopharyngiomas occurs only in adults. In the minority of adults, it's rarely calcified. It's generally very well circumscribed, and instead of having this motor oil fluid, it has a very yellow, viscous, mucinous sort of fluid. Shown here is the incidence of adamantinomatous and papillary craniopharyngiomas in the population, and you can see it's extremely rare to ever have a papillary craniopharyngioma below the age of 20, whereas the adamantinomatous are by far and away the most common type of craniopharyngioma. So here's a picture, a surgical picture from a craniotomy. And in the slide here, my arrow is pointing to a retractor. There's two retractors in here, the silver retractors. The left one is pulling up the frontal lobe, is lifting it up. The right one is pulling up the temporal lobe. This up above is the dura, which is a skull base, and you're pulling up and looking right down into what's called the suprasellar area. And here you can see the capsule of the tumor, this kind of grayish-brown capsule. It's pushing the optic nerve, which is this structure right in the middle, the optic nerve upward and stretching it. Right next to the optic nerve is the internal carotid artery, which is getting stretched over the side of the tumor. and way over here is one of the cranial nerves, cranial nerve 3. But to remove this tumor, you've got to open up the capsule, drain the fluid, and then get it away from its adherence to all of these structures. This is what a papillary craniopharyngioma, the contents of a papillary craniopharyngioma look like. And here we're opening the tumor, and you can see this yellow mucinous material that the tumor tends to be filled with. So moving on, radiographically, there's really no reliable way on a MRI scan to tell one type of tumor from the other, except for possibly the calcification will lean you more towards adamantinomatous than papillary, but it's not a definite way to tell the difference. The only way you can really tell the difference is looking at under the microscope. So here, radiographically, I've shown two groups of tumor. Here's the adamantinomatous tumors. This is a side view MRI scan, what's called a sagittal MRI scan. And here's three different tumors. Shown, the one on the left is a very large cystic tumor pushing up on the frontal lobe, and then two smaller tumors, which are partially cystic, partially solid. And then here's actually 5 different papillary craniopharyngiomas, and really it's very, very difficult to tell the difference of one from the other. So what exactly do patients tend to present with? Well, these tumors we know are very slow growing, and because of this, symptoms tend to predate the diagnosis by about 1 to 2 years. And this is pretty typical both in adults as well as in children. In adults, they tend to present with visual symptoms as well as signs of hormone dysfunction from pressure on the pituitary gland and the pituitary stalk. Children also present with visual symptoms and hormone dysfunction, but they also tend to show evidence of slowing in their growth, in their sexual maturation. They tend to have weight gain and can develop problems with the flow of spinal fluid and develop hydrocephalus. As we talked about, the posterior pituitary gland is involved in the secretion of the antidiuretic hormone, and if you lose that, you develop the diabetes insipidus, which is seen in about 6 to 38% of cases at the time of presentation. This is a slide by Dr. Cohn, and basically shows the clinical manifestations before diagnosis of craniopharyngioma in 138 children and adolescents. And you can see that the two most common symptoms are definitely headache and visual impairment. That's followed by growth retardation, difficulties with attention, the vigilance deficit, the diabetes insipidus, which is the difficulty in concentrating the urine, and finally weight gain. What about the visual abnormality? Well, classically, the vision problems come on very, very slowly. So often, even though they are there, they're not noticed by the patient. Because vision problems tend to be due to the tumor pushing up on a structure called the optic chiasm, and that's where the optic nerves cross, you tend to lose your vision in the periphery. It starts out either with a quadrant defect on each side in the periphery, and that can be down below or up above, depending on which direction the tumor is pushing on the optic chiasm. So here's just an example of two different visual fields, and the black is where the patient can't see, left eye on the left, right eye on the right, and then the one on the right is a more severe vision loss where they've lost almost completely the peripheral vision. Again, it happens so slowly that the patients themselves are often very unaware of it. Finally, there is something called the hypothalamic metabolic syndrome that we see with craniopharyngiomas, and this is related to pressure on the hypothalamus. This is the structure that's up in the brain that the tumor tends to grow up into, and this involves your ability to control whether you're hungry or you're full. It also controls your energy expenditure, and as a result of this, there tends to be weight gain, problems with lipids, hyperinsulinemia. There's too much insulin in the bloodstream, but there's a relative resistance with the development of diabetes, and there's elevated blood pressure. So, what about treatment? We're going to move on to standard treatment, but some of the newer treatments that we are now using for treatment of craniopharyngiomas. And treatment has always been a balance. It's a balance between radical surgery with an attempt to take out all of the tumor, but that has to be balanced against the risk of injury to the brain and permanent neurologic symptoms. So there's a balance between a more conservative approach with a subtotal resection and the use of our adjuvant therapies such as radiation therapy. And that balance is really a balance between trying to give as long a survival or as lowest chance of recurrence as you can versus causing neurologic damage. So the trend on how we treat craniopharyngiomas has really changed since the 1970s. In this graph, and shown on the left is, in the blue bar, is the percentage of patients who underwent attempted gross total resection. GTR is gross total resection. Between 1975 and 1989, 90% of all craniopharyngiomas, there was an attempt at gross total resection with only 10% subtotal resection. 1990 to 2001, the middle graph, this dropped to about 86% gross total resection and 12% subtotal. And then in the early 2000s, it dramatically changed where surgeons and oncologists felt that the morbidity, the injury from surgery was too great, and only 10% of patients underwent gross total resection, with the majority undergoing a subtotal resection or a decompression for diagnosis, followed by radiation therapy. So there's been a huge change. I think that pendulum may be swinging back a little bit as we've developed less invasive surgical approaches. The number one priority, and I want to stress this rather significantly, is that in treatment of craniopharyngiomas, it's a very complex disorder involving not only the neurologic system, but the endocrine system and the rest. That it really requires a multidisciplinary team, and at the minimum, this team should consist of an endocrinologist, a neurosurgeon, a radiation oncologist, and an ophthalmologist. Obviously, for children, a pediatrician, and the rest. But it really needs to be treated not by a single subspecialty, but by the whole group. And I think that will offer the best care in treatment of these patients. So what about surgery? Typically, surgery has consisted of a craniotomy, as shown above here, with an attempt to take out as much tumor as will come easily, as we often say. If we can get it all out with minimum morbidity, minimum damage, then that's what we like to do. But if we can't, as the trend has shown, we'll back away and depend on our other adjuvant treatments like radiation. The craniotomy is slowly going by the wayside. Not completely, but slowly, for other minimally invasive approaches, one of them being the supraorbital keyhole approach, which we'll show in a second, and then more importantly, the transnasal endoscopic approach. And I'm going to make an argument here that I think that this is going to be the approach, if indicated, for most of these tumors. Now again, it should be stated that which operation a patient gets is very much dependent on the tumor location, the patient, and the structures that it's adherent to. So the supraorbital approach is now a more minimally invasive craniotomy. It still is a surgery that goes into the brain, but this time using a little incision in the eyebrow, as shown on the right-hand side, and through this incision, a very small cranial opening going underneath the right or left frontal lobe. The transnasal endoscopic approach is completely different. This is an approach coming up through the nose, going into the back of the nose into an area called the sphenoid sinus, which is an air sinus, and then up into the pituitary and the tumor from this direction. So this is a picture that I showed earlier of the adamantinomatous craniopharyngioma in the upper left, and this is viewed through a craniotomy. So you're elevating the frontal lobe and we're elevating the temporal lobe. We're seeing the tumor. In order to remove this, you've got to work around the carotid artery. You've got to work right around the optic nerve. And here in the lower right is shown the tumor after resection. You can see the other optic nerve kind of in the depth here. Here's the right optic nerve. Here's the left optic nerve. Here's the chiasm that connects them two. But the tumor goes underneath the chiasm and up into the third ventricle. So you can see from this approach, you really don't have terribly good visualization of these structures underneath, and you kind of depend on the capsule delivering itself from this area or leaving that capsule in an area that you can't see very well. So that's the limitations of a craniotomy. When you look at how, in this next slide here, if you look at how tumors grow, on the left-hand side you see a partially solid, partially cystic tumor right here. They kind of grow up in a line that follows this yellow line. When we do a craniotomy, we're coming at the tumor along this red dotted line and then trying to work around a corner to get up to this cyst. Right at that corner is the optic nerves, which makes them very susceptible to any injury. What if we could come in right along this yellow line? That would give us the best exposure to all of the tumor, the solid and the cystic portion, and we'd be coming underneath the optic nerves. Well, that's exactly what an endoscopic approach does. And here is a picture of the base of the skull, looking with an endoscope through the nose at the bone at the base of the skull, and you can see the bulge in the middle is the pituitary gland. You can see the bulge on each side that says OP, that's the optic nerves, the optic prominence, where they come out, and then you can see where the carotid arteries are on each side as well, where the CP is. If you take this bone away, this is what you see. You see the pituitary gland. You see the pituitary stalk. This is the area where almost all of these craniopharyngiomas start, and then they'll tend to grow backward under the chiasm. This is the optic chiasm into the third ventricle. With a craniotomy, you're attempting to come from above and work around the chiasm. In this approach, you're actually following up along the axis of the tumor itself. So here is another picture showing that there needs to be a fairly extensive bone resection along the base of the skull. This is underneath the frontal lobes. This is the pituitary. This is the clivus. So this bone right in this region needs to be removed to get at a craniopharyngioma. But you also have to work in between both of the carotid arteries and not damage those arteries. So here's an example. This was a 19-year-old, young female who presented with this partially cystic, partially solid tumor while she was at college. And on the side view on the left, you can see it involves the pituitary gland down below and then grows up into this region of the hypothalamus and the third ventricle. The optic nerves are sitting just in front of it, and on what's called a coronal view, where she's looking straight out at us, you can see that the tumor extends quite a distance up into the brain, with the hypothalamus lying just on either side of the tumor. With the endoscope, and here I've got 4 pictures that show the endoscopic approach. In the upper left-hand corner, we've taken the bone off. You can see the frontal lobe up above. Here's the optic nerves, and you're not having to work from above around them. You're looking right underneath the optic nerves, and you can see the tumor. This is the tumor itself, a little bit adherent to the underside of the optic nerves, but relatively easily separable. Here on the right upper corner is the tumor being slowly removed along with its capsule. Once removed, we can actually look underneath the optic nerve, as shown here, right up into the third ventricle and the hypothalamus. And you can see over here, this would be the patient's left because they're lying on their back. The tumor was adherent to the wall of the hypothalamus, but relatively easily stripped away the capsule of the cyst. And here at the end, in the lower right-hand corner, you can see this is an inch division here. You can see this is 2 centimeters, a fairly small opening that you're working through, but with the endoscope, everything is blown up quite nicely. So that's the transnasal endoscopic approach, and I think it's becoming more and more common as the initial surgical operation for these tumors in those that are aligned in this direction, but that really accounts for a lot of these tumors. And then here is the post-operative picture, the side view on the left and the front view on the right, showing that, in fact, there was a nice gross total resection of this tumor. So what about surgery? Yeah, surgery commonly is stated that about 20%, 18 to 24% of tumors can be completely removed surgically. So it's by far and away the minority of the tumors at presentation. Even with a complete resection, about 25% will recur after about 83 months or 6 years. When you look at the literature, and this is from Craniopharyngiomas, after gross total resection, the literature, the recurrence rate is anywhere from 0 to 26%. And after subtotal resection or partial resection, it can be from 25 to 100%. If you add radiation therapy, XRT, to these tumors at the time of removal, your recurrence rate does drop down to 10 to 63% at 10 years. And you can notice these are very, very widely, percentages varying, but it depends on different. It's very hard, since these are relatively rare tumors, to get any really large series. So there's a lot of variability from one series to another. What's interesting is that the age at diagnosis, male versus female, gender, tumor size, location or consistency, or histologic subtype did not seem to affect the risk of recurrence. The amount of tumor removed, however, does. So with subtotal resection, we generally turn to radiation therapy or radiotherapy. And I'm going to just briefly talk about this. But radiation therapy is, at this point in time, a mainstay of the treatment of craniopharyngiomas. And we've advanced the machines that we use for radiation therapy to the point where we can pinpoint that radiation to a very small area of the brain. Conventional radiation therapy using what's called IMRT approaches, we generally deliver small fractions of radiation once a day, 5 days a week for 5 to 6 weeks, and we get about 54 to 55 gray. This is the best. We have the best experience with this type of treatment over 40 years of treatment. More recently, we've started to use stereotactic radiosurgery, and again, stereotactic radiosurgery, and again, this is not necessarily applicable to each patient. Stereotactic radiosurgery delivers a very high dose of radiation in 1 or 2 or 3 fractions, but because of the high dose it delivers, you can't treat lesions that are around the optic nerves or around very eloquent structures in the brain. And then there's some experience as well with the proton beam. by the way, stereotactic radiosurgery is basically delivered by several different machines. The gamma knife is one. The cyber knife is another type of stereotactic radiosurgical device. The Novalis Brain Lab is a third. So they're all different machines that really do the same thing. So I'm going to end this talk with a discussion of something that's really very exciting about the treatment of craniopharyngiomas, and that's really the new area of targeted molecular therapy. This is something that is becoming very real in the treatment of these tumors. In the adamantinomatous craniopharyngiomas, remember the ones that occur primarily in children and account for the majority in adults, we've identified a pathway called the Wnt beta-catenin pathway that gives rise to these tumors. Identifying that pathway, it's an abnormal tumor pathway. By inhibiting the pathway, there's promise that you can slow down or completely stop the growth of these tumors. In papillary craniopharyngiomas, just in January of this year, a mutation was identified that occurs in about 95% of these tumors called the BRAF, B-R-A-F V600E mutation, that when you target a drug against this mutation, it can cause dramatic regression of the tumor. So we'll talk about that a little bit. This is a very complicated slide, and I apologize about it, but on the left is shown the normal, this is the pathway within the normal cell that beta-catenin, which is a protein inside the cell, normally goes. And beta-catenin is generally phosphorylated. It has a phosphorus compound added to it by this enzyme, this blue enzyme. And then once it's phosphorylated, it can be broken down inside the cell, so there's never too much beta-catenin inside the cell. On the right-hand side is what happens in a craniopharyngioma, in an adamantinomatous craniopharyngioma. This enzyme, because of this Wnt attaches to a surface molecule, it takes up part of the enzyme, it breaks the enzyme apart, and this beta-catenin doesn't get phosphorylated, and then because of that, you get too much of the beta-catenin. It doesn't get broken down within the cell. Well, too much beta-catenin leads to all of these cytokines being overexpressed inside the cell, and it gives the profile of a craniopharyngioma. So if you could develop a way to downregulate this beta-catenin overproduction, it's extremely promising for controlling these tumors. So the future for adamantinomatous craniopharyngiomas is to develop targets to inhibit this Wnt beta-catenin pathway. At present, they don't exist. However, and I'm going to go back a slide here, some of the cytokines, like vascular endothelial growth factor, VEGF, that are produced as a result of beta-catenin, in fact, do have drugs. This is a drug called bevacizumab that inhibits VEGF and can be used against these tumors, and there's some studies starting that are using this in craniopharyngiomas. And then there's epidermal growth factor, another one of these cytokines that's overexpressed as a result of this abnormal pathway. And we have a drug right now that can inhibit EGFR called gefitinib. There's also looking at agents that will increase some of the other, that will work against some of these other cytokines that are overexpressed, like macrophage inhibitory factor and galectin-3. In addition, for adamantinomatous craniopharyngiomas, we have recently discovered that they lack an enzyme called MGMT that breaks down a chemotherapy drug called temozolomide. This is a drug that we use commonly in gliomas, primary tumors of the brain. So there's some work now going with the use of temozolomide in treatment of craniopharyngiomas. And then tamoxifen, a drug commonly used as a suppressive drug for breast cancer, has been shown to experimentally inhibit craniopharyngioma cell production. So there's a lot of new drugs that are being used or in development for treatment of adamantinomatous craniopharyngiomas. For papillary craniopharyngiomas, again, just January of this year, Brasilianos and colleagues published in Nature Genetics that 95% of these types of craniopharyngiomas have this BRAF V600 mutation. Well, BRAF is also seen in melanomas, and we have a drug that's FDA approved. In fact, we have two drugs, vemurafenib and dabrafenib, I can barely pronounce that one, that inhibit this mutation, and we're starting to see some very dramatic responses to the use of these two drugs in the treatment of papillary craniopharyngiomas. So in conclusion, I think the future is very bright in the treatment of craniopharyngiomas. There's improved surgical approaches that really approach the tumor along its normal axis of growth, minimizing perioperative morbidity. We are using more targeted radiation therapy to subject the brain to less and less radiation. And then there's these continued advancements in the molecular characterization of tumor tissue. And as this continues, we really are developing new and improved targeted therapy aimed at these molecular abnormalities. So I'd like to thank you, and this is the end of my presentation.
Thank you so much. That was wonderful. And we do have some questions that were populated beforehand, but I'll also remind you, those that are online right now, if you have a question that you would like to ask, please type and submit it using the question box at the webinar control panel, which is on your right-hand side of your screen. But I will start with some questions that, like I said, people typed in when they registered. Someone is wondering about, is there any research that human growth hormone may cause a higher rate of recurrence in craniopharyngiomas?
Good question. Not that I'm aware of. Growth hormone tends to be one of the earliest hormones that diminishes as a result of the craniopharyngioma's pressure on the normal pituitary gland. But I'm not aware that elevation in growth hormone will cause the tumors to grow or become more invasive. Interesting, excessive levels of growth hormone are known to cause a lot of different types of tumors elsewhere in the body, but I don't know the connection between craniopharyngiomas.
Okay. Do you know about the long-term quality of life impact of proton beam therapy on someone with a craniopharyngioma?
That I can't, I'm really not an authority on that. There certainly is a good experience for many, many years out of Boston with the proton beam facility, and it does deliver a very high dose of radiation. So there are long-term effects down the road, but I can't speak specifically to the proton beam.
And someone's asking.
I might add one other thing. I think ultimately we would certainly like to get away from the use of radiation therapy completely, because there are long-term down the road, delayed effects of it. But right now, it still is an important part of our treatment regimen.
Okay. And at what age do you start radiation treatment on young children?
And that's a great question, and I'd have to defer that to a pediatric oncologist. But the question really addresses the fact that radiation does have effect on growing cells, growing brain cells, and certainly in young individuals where the neurons and the rest are still, the brain is still developing, radiation has much greater effect than it does in treating an adult. So certainly I would say younger than 2 to 3, they don't like to use radiation at all and try to bide over with chemotherapy. But above 3, I think they tend to get a little bit more favorable to radiation.
And we have a couple of questions about scar tissue from prior surgery. Does it make subsequent surgery more difficult or impossible?
It certainly makes yes. The answer is yes. It does make it more difficult, and you know it's a combination of scar tissue plus the fact that if there was tumor cells left behind, they're probably very infiltrative. They're probably very adherent to begin with. So that's the part of the tumor that's left that's the most difficult to remove. So your best chance at surgical resection is your first operation, and then it becomes increasingly more difficult after that.
And you were talking about you know, the age and sex and everything about recurrence. So is that on just recurrence, or does that affect growth rate too?
No, that's just recurrence, and that's some of the newer data. That's a bit controversial, but it seems to be holding up. There are, I didn't touch on this, but there are there's some other, in the molecular biology, when they're looking at all these different proteins and cytokines, they have identified several cytokines that tend to be present in the faster growing versus the slower growing tumors. So I think it's more related to what's in the tumor itself, what the molecular biology of the tumor is, more than anything else.
And we have one more question, unless anyone has one to type in, asking about heart palpitations and dizziness. Does that have any relationship to craniopharyngioma?
When tumors are up into the third ventricle and into this region of the hypothalamus, it can certainly result in an autonomic dysfunction, and patients can have rapid heart rate and that sort of thing. So yes, it can give rise to palpitations, and also obviously you have to be careful about dehydration with diabetes insipidus. But yes, irritation in the region around the hypothalamus can cause those symptoms.
Wonderful. Wait, I have someone who posted one more question. They don't want you to end yet, so hold on. Is there research regarding breaking down whatever makes the tumor more adhesive?
Yes. Yes. There are. And again, I didn't, this macrophage inhibitory factor and galactin-3 are two molecules that tend to be very low in tumors that are more invasive. And they're looking at drugs that can affect the level of these two proteins right now to see if they can turn tumors that are invasive into less invasive tumors. It's very preliminary work, and it's mainly being done in the laboratory at this point.
Great. Well, I think we've wrapped up all the questions that we have for now, so I think that's wonderful. You tackled them like a champ. I want to thank everyone for joining us, and I want to thank you again, Dr. Lillehei, for all the information you provided for us today. I would encourage people to find more information on craniopharyngiomas at our website at www.abta.org. And you can give us a call at our care line at 800-886-2282. So we're going to pause just for a moment to stop our recording.